Thank you all for joining us on a Wednesday evening or afternoon or morning, depending on where you're coming in from. So give me just one moment. I'm going to get my screen up and shared here, and then we can get ourselves started. So what we're going to talk about over the next 50 minutes or so is really going to be talking directly about shockwave therapy in the area of orthopedic management, and talking about what do we know, maybe what do we not know, and then hopefully give you some things to take back into practice if you're considering using shockwave therapy for your patients. So a few disclosures before we get started of companies that I lecture, consult, or receive research funding from. I don't receive any royalties from any companies. So let's start thinking a little bit about where extracorporeal shockwave therapy or shockwave therapy may help out with our patients, and hopefully to get your mind rolling a little bit of where we might think it could be beneficial for us. And so let's say you're presented with this patient tomorrow, for example, and we watch this dog walk, and we can all agree that this dog has a left front limb lameness. There's a noticeable head bob when the right front leg hits the ground. Let's say you do your examination and you really don't find much in terms of pain, but maybe you get some resistance or some spasm in the shoulder region, and you take radiographs of the shoulder and the elbow, and it looks completely normal, and you're going under the assumption that maybe this dog has some sort of tendinopathy of the shoulder. Alternatively, let's say we have a patient that has a radius and ulnar fracture that was repaired with an external skeletal fixator such as this, and this dog is 6 weeks post-operative, and we take these radiographs and we can see that there appears to be some bony activity, but for me as an orthopedic surgeon, this is not the type of healing I would want to see at 6 weeks. I would want to see a little bit more progressive healing, and so perhaps utilizing shockwave therapy to help stimulate bone healing could be a consideration. But like anything, we also have to understand our limitations. So, for example, if the surgeon who did this was very aggressive and destroyed the biology of the antebrachium, that could make it difficult for bone to heal, or maybe there's an overly robust method of fixation, and the fixation is too stable for the bone to try to heal. And so we also have to understand the limitations of any sort of modality that we're going to use. And then lastly, we have two patients here. The radiograph on the left is a dog that has bilateral hip laxity and bilateral hip osteoarthritis, secondary to hip dysplasia. And then the image on the right is a patient that has moderate to severe elbow osteoarthritis, secondary to developmental elbow disease. And so these are both patients with osteoarthritis, and I know there's lots of different types of multimodal management strategies for osteoarthritis. And so the question then becomes, could shockwave therapy play a role in helping with the management of our arthritic patients? But again, we also have to understand the limitations of what we're utilizing, and recognizing in particular for a patient with osteoarthritis, where on the spectrum of that disease are they? Are these patients that are in the middle of a flare-up, or are these patients from a more routine maintenance standpoint that are not in a flare-up? And so we also have to remember to understand and recognize and thoroughly work up these patients when we're going to recommend some sort of modality. And so we've run through kind of three different scenarios where we might consider using shockwave therapy. And so I really want us to kind of get through three major objectives from tonight's presentation. One being to first define what shockwave therapy is, and then discuss some of the different types of units. For me, a lot of it is going to be evidence-based to say, what do we know, what do we not know, and what can we extrapolate from the literature to apply to our patients clinically. And so I want us to appreciate the currently available literature on the usage of shockwave therapy. And then lastly, describe, as we talk about those different areas where we have known literature available than to describe the clinical usage of shockwave therapy for various orthopedic conditions. And you can imagine that we went through three scenarios: a tendinopathy, bone healing, and osteoarthritis, that we're likely going to talk about the literature on those types of pathologic processes, as well as how we can utilize shockwave therapy clinically for those. And so first, understand that with shockwave therapy, it's really like anything when it comes to veterinary orthopedics, and it's simply just another tool in the tool belt that can be utilized to help facilitate healing with your patients. You know, while it could be used in some situations as a standalone treatment modality, many a times we're going to get the best benefit by first having a definitive diagnosis of what's going on, but also directing things from multiple fronts and coming in and offering multiple different management strategies for our patients. And so just a little bit on the history of shockwave therapy. You know, interestingly enough, this was used back in the 1970s to help break up uroliths. And so, like most things, dogs were a nice model for human diseases. And so they were doing research with dogs, and you know, somebody discovered that when they were utilizing shockwave therapy, they started to note there was some callus formation and some bony remodeling around portions of the pelvis. And so they thought, maybe there's other uses for shockwave therapy that could be done. And so since the 1970s, we've seen it used for various musculoskeletal conditions such as osteoarthritis or tendinopathies, as well as pain management, and then delayed and non-unions. And so, like most things, when we talk about the rehab world or even the sports medicine world, it's been widely accepted for longer on the equine side of things, as well as in some situations on the human side of things, really before being adapted to our canine patients. And, you know, I don't know if it's just me, but I feel like I hear more buzz about shockwave therapy. I hear people talking about it more probably in the last 5 or 7 years. And so perhaps maybe it's gaining a bit more traction. I think certainly for some of these really frustrating conditions, we're evaluating all sorts of different areas where we can provide help. And so, contrary to the name shockwave, it has absolutely nothing to do with an electrical shock. It's simply a physics term. And so if you say, well, gosh, if you're not applying an electrical shock to a patient, then what in the world are we doing? And the best way to think of this is simply like a high energy sound wave or impulse that gets created. And so it's established by a change in pressure. And so probably the best analogy to think about is sort of the lightning thunder scenario. For example, lightning is going to be that electrical impulse that creates this change in pressure, and then the thunder that follows would be the sound wave or the shock wave. And so think about in some situations when that happens, you can feel the windows or the walls shaking. But the difference is that all the windows and the walls of your house shake, and your neighbor's windows and walls shake. And so while this is a similar scenario to the creation of a shock wave, it's not focused. It's not picking up just the southeast corner of your house and just that wall shaking and nothing else. So it's not focused. But the theory here is, can we take the same thought process and create something focused to direct that energy to tissue for some sort of healing response? And so that's what we're wanting to achieve. And if we get into the nitty gritty, we need to say, well, what is a shock wave? And it's really this acoustic nonlinear wave that is generated from a change in pressure and velocity outside of the body. And so we have this graph here because there's several characterizations needed to call something a shock wave. So for example, there needs to be a low tensile amplitude, but notice that it's going to very quickly rise from a net zero to its peak pressure. So in this graph, for example, it's 33 nanoseconds, very, very fast. But it's also going to be very short. It's not going to spend a lot of time at that high altitude. And then there's going to be this slight negative dip. And this slight negative dip is actually very important because what it does is it creates this cavitation that increases cellular permeability. It generates the production of free radicals, which in some situations can be a good thing for cell biology, but it also helps release anti-inflammatory mediators as well. So that slight negative dip is very, very important when we're defining something that's producing a shock wave. And so the way this is done is there's some sort of generator or a trode that or unit that produces mechanical energy from an electrical source. So there's some sort of electrical stimulus that produces this mechanical energy within a fluid medium, and then that creates this pressure wave within the trode to generate our sound wave that is then relayed to the treatment site within the body. And so we really appreciate three types of focused shock wave. There's electrohydraulic, electromagnetic, and piezoelectric, which we'll talk about all three of these. So an electrohydraulic shock wave, there's a little spark plug in the trode. And when it's plugged in and turned on, the electrical energy is going to fire the spark plug, which creates that sound wave. And so it's been described as being a true shock wave at all of the different energy settings. There's a bit of a larger focal area. So when it's delivering that sound wave, it's delivering it to the tissues in a little bit of a wider surface area. It has a relatively high peak pressure, and then it gets there very, very quickly in terms of nanoseconds. Versus an electromagnetic shock wave where there are these coils in the trode. So think about like a old speaker. And again, once that's plugged in and there's the electrical energy, that creates these opposing magnetic fields within those coils that then focuses the sound to generate these low pressure waves. And so it's been described as being a true shock wave at higher energy settings. The focal area is a little smaller that's delivered. The peak pressure isn't quite as high as an electrohydraulic machine. And then it gets there still very quickly, but a little bit slower than the electrohydraulic. And then lastly, we have our piezoelectric, which have crystals in the trode. And so again, that electrical impulse causes those crystals to expand and deform, and that causes the release of the sound wave. And so much like the electromagnetic, it's been described as being a true shock wave at higher energy settings. There's a little bit of a smaller focal area, and then the peak pressure hits at about 15 MPa, so still a bit lower than our other two, and the rise time is also very quickly in microseconds. And so there are some subtle differences about when the actual sound wave is hitting the tissues and when it's considered a shock wave, whether it's outside of the body at the trode or whether it's considered the sound wave when it hits the tissues. But you may also come across radial pressure waves, which aren't truly shock waves. It's described as a pressure wave because the waves are actually longer, they're slower, they're not as intense, and they're shallower in their penetration. So it doesn't really produce a true shock wave, because if you look at the peak pressure, it's very, very low compared to our other three devices, and the rise time tends to be in milliseconds. And so then you think to yourself, well, gosh, why in the world does this even matter? You know, realistically, tell me what it does, why I should use it, what I should use, when I should use it, and all the happy-go-lucky things. But realistically, while all three of these may deliver shock waves at various stages, the energy settings are not comparable. So it can sometimes be a little bit difficult, especially if you're deriving information from one study and then you have a different unit to apply that to your patients to assume you're going to get the same outcome. Because the amplitude and the focal depth do vary considerably between machines. And so you may see that protocols may vary. And a lot of these protocols are set by the manufacturer. And so, for example, with a piezoelectric protocol, you may see that they recommend 2,000 to 3,000 pulses per treatment for 2 to 3 times a week, and so that treatment is getting 18,000 total pulses versus the same condition for an electrohydraulic machine may be 1,000 to 1,500 pulses per treatment, and maybe they recommend treating them 1 to 2 times every 2 to 3 weeks for 2,000 to 4,500 pulses. And so, what we have to realize is that, again, we can't extrapolate from one to the other because there are some differences. But it should be noted that to date, there are no randomized controlled clinical trials in animals that demonstrate superiority between the various machines or treatment protocols. And so we don't want to try to say necessarily one is better than the other, but we need to understand that particular machine that we have and how it's being utilized for the treatment that we're administering for a various condition. So the mechanism of action is really not fully understood or known. However, there's this release of that mechanical energy. So the sound wave hits the tissues, it causes this mechanical energy, and at the tissue level, it's thought to help increase expression of various cytokines and growth factors. It's thought to help decrease inflammatory mediators, as well as promote neovascularization, improve cellular proliferation, and upregulate resident stem cells. And so, for me, those 5 things are very important when it comes to tendinopathies, for example, because, in an acute stage, we might have inflammatory mediators, but for a lot of these tendinopathies, they're chronic. And realistically, previous biopsies have shown that there's not a lot of active inflammation going on, but there's also just not a lot of cellular activity. And there's typically poor blood flow at the origin and insertion of many of these tendons. And so if we can increase growth factors to facilitate healing, if we can increase blood flow to get reparative cells to the area, if we can improve the cell biology going on, if we can also upregulate resident stem cells to help repair tissue, I think all of those things can be very beneficial for our patients. And then there's also an analgesic effect, and it's thought to increase serotonin levels through the gate control theory to help provide some degree of pain relief, which we'll see from some studies here in a little bit. I do think there's likely an analgesic effect to explain some of the changes that we see. And so the primary effect is the generation of those forces with the secondary effect, that cavitation. So, that primary effect is the sound wave hitting the tissues, causing those changes that we just talked about. But then also remember that slight little dip gives us that cavitation and increases permeability of the cell membranes, and then results in production and release of free radicals, as well as decreasing inflammatory mediators. But there's also one other thing. There's once the sound waves hit the tissues, there's going to be compression and tension that's going to occur to those tissues. And as the sound wave moves through the tissues, that's going to occur at various levels. And that's a term called mechanotransduction. And that's going to also stimulate cells for various biologic responses, because we know that cells, in particular tendinocytes and ligamentocytes, they actually respond to stimulus. The last thing we want to do, for example, is take an Achilles repair and completely immobilize it for a very prolonged period of time, because there's no mechanical stimulation of loading to that tendon to generate biologic responses for tissue healing. And we're able to achieve some of that with one of the attributes from shockwave therapy. So right now, at least on the human side, it's been FDA approved for plantar fasciitis, but then there's also multiple clinical trials going on, as well as, and I didn't know this was a thing, but the International Society for Medical Shockwave Therapy has several trials and supports the usage for the chronic tendinopathies of shoulders, Achilles, patella, as well as delayed and non-unions, stress fractures, myofascial pain, which is an area that we don't talk a lot about on the veterinary side. That there are some individuals out there that have some really great thoughts when it comes to talking about myofascial pain and how it relates to movement of the tissues above and below, but also as a potential source of discomfort in some of our patients, either from compensatory issues or following surgery or that sort of thing. And then also lastly, usage for osteoarthritis. But in our patients who we're treating, we see a wide range from fracture and osteotomy healing, tendinopathy. So if you look at these two radiographs, there's a little bit of mineralization at the insertion of the greater or the lesser tubercle from the iliopsoas, versus a little bit of calcification in the region of either the supraspinatus or the biceps in this shoulder. And then this is an arthroscopic image of a dog that's got some mild fraying. If we look, we're looking at our subscapularis here, which doesn't look too bad. But if we zoom out in a moment, we'll be looking at the medial glenohumeral ligament, where we can see some mild fraying and tearing to the medial glenohumeral ligament. And so, this is a patient that has some degree of medial shoulder syndrome. And, I, for one, and I think many of us that do both surgery and sports medicine and rehab really fight with this disease condition. And what do we do? The question is could that be a viable alternative for some of these patients? And so from the usage of this, they can either be sedated or they could be done unsedated, such as this first video here of this older shepherd being shockwaved on the stifle, versus the second video. This is a patient of mine I was recently treating shoulder, and this dog is unsedated as well. And you can see that he could really care less that he's undergoing treatment. So he handled things very, very well. Ideally, we want the hair clipped or at least parted. So you can see with this shoulder I'm treating, we've got the hair shaved. We've also done a musculoskeletal ultrasound and some injections, but for the best effect, we want the hair shaved or parted. There needs to be some sort of coupling gel between the skin and the applicator. So that's typically going to be using like ultrasound gel. And then also starting to understand the regional anatomy. So for example, for the joint, we want the probe directed more around at the joint capsule and the periarticular tissues rather than right at the articular cartilage. Because, what we don't really understand is if we, take our little chondrocytes that are these nice, awesome little cells and we blast them with this sound wave and cause them to bounce around, is that going to create damage to them or not? For tendon and ligament issues, we're typically moving from proximal to distal direction, so we can make sure that we're hitting those areas as we would like to treat. Now, how many pulses we provide to an area is going to vary, anywhere from 500 to 1500 per location per treatment. The optimal energy density, meaning how many millijoules per millimeter squared, the number of applications, the number of sites per application, we really don't fully know that yet. And so right now, what we typically do is follow manufacturer recommendations in their settings. They typically have it laid out for us. A lot of the treatment protocols are going to be around 2 to 3 treatments separated by 2 to 3 weeks apart. So we ideally want to keep the trode parallel to the tissues. We also want to move the trode during treatment to ensure that those waves are penetrating the tissue of interest. For example, this is a dog that's getting shockwave to the hip region. And while that's being delivered, I think it's effective, but to me, this is just moving it a little too quickly. I tend to move it a lot slower. So that way we have time to deliver impulses to that particular area rather than trying to move it really quickly. I found that using earplugs, now if you're sound sensitive to various units, you yourself can use earplugs, but we use cotton balls in all of our patients to help decrease the sound on some of these, and they tend to tolerate that very well because it doesn't necessarily hurt to treat them with shockwave, but sometimes the sound can be a bit off-putting for them. And so it is well tolerated by our patients. You might see some initial discomfort during treatment, especially if it hits an area of pain. Following the treatment, you could see local bruising or a little bit of petechia or maybe even a hematoma develop or some localized swelling. And then, they might be a little bit more lame for a few days following treatment. I typically tell owners that any abnormality that we see is typically going to resolve within about 48 to 72 hours. And so I typically tell them we'll see 1 of 3 responses in the immediate period after a treatment, one being absolutely no change at all, another being an immediate improvement in lameness due to the analgesic effect, or a slight worsening of lameness following treatment. And then the loud noise could create an aversion and induce anxiety. So again, I think using earplugs can be very helpful for our patients there. So there's always contraindications, and most any of our rehabilitation modalities are going to have these same contraindications. So we don't want to shockwave over a malignant tumor. I'm not going to jump in because I don't do any sort of surgical oncology to talk about, well, if we remove a tumor, is it beneficial to use shockwave therapy? Certainly if a dog is pregnant. Around the shoulder, we probably want to be a little careful that we're actually aiming the trode to the tendons of the shoulder and not hitting up the lung parenchyma. We don't want to cause something like a pneumothorax. We don't likely want to shockwave right over a growth plate, but the evidence isn't just overwhelming for yay or nay. Brain, spinal cord, some evidence suggests there could be improvement in nerve regeneration, but I would probably be pretty cautious. We also want to be very cautious over large vessels or patients with coagulopathies, because remember, you are delivering a sound wave to these tissues and you're going to get some changes, and we don't want to create any problems. And we also want to be cautious with patients with immune-mediated joint diseases. So let's look a little bit at the literature. I'm going to try not to get too boring. I'm going to try to avoid talking about all of the kind of like rat and mouse studies and some of the boring things, but I think saying what is going to be beneficial for us, for our clinical patients. And so we're all very familiar with evidence-based medicine. And if we look at the literature in the veterinary side, right now we have evidence for bone healing. We have evidence for tendinopathies, for desmopathies, and for osteoarthritis. And so if we start with bone healing, the starting aspect of this, and what you'll notice is the general theme with these is all about decreasing inflammation, upregulation of biologic healing responses. And so for the bone, it's thought to release osteoinductive growth factors. It's thought to recruit bone marrow stem cells to the area to help with healing. It also helps increase various proteins within our bone morphogenic proteins, and then also increases the quality of bone by showing an increase in bone mineral density, but not just increasing the quality of bone, it improves the biomechanical qualities of the bone because we can see a higher peak load, meaning the bone's stronger, higher peak stress, which means it can handle more of a load before it hits that catastrophic failure. And then the elastic modulus is improved as well. And this is all pertaining to fracture repair. And so where we kind of get a little bit of initial information takes us back into the mid-1990s, where there was this study on radial non-union models in dogs. So basically we know that if we cut bone and we take so much bone away, it's going to create a non-union. And so they took dogs that were treated with shockwave therapy and a control group. They found that the majority of the dogs had callus formation by 6 weeks following shockwave therapy, and then had full healing by 12 weeks, versus at the 12-week mark, the majority of the control dogs had radiographic non-unions. And so we can see an image, the upper left is what that control looks like, and that certainly looks like a non-union where we have the gap. We've got some rounding of the bone ends. There's not really good callus formation to suggest biologic activity, versus in our shockwave treated patients, we see that at the 12-week mark, while the bone isn't fully healed, it has bridged quite nicely to show that there is really nice biologic activity going on. Now, I think more clinically applicable would be two of these studies, which are both TPLO studies. And they're actually quite interesting because, first off, they're a level 2 study. So the evidence is strong and there's a low risk of bias. In both of these studies, the dogs underwent 1,000 pulses immediately after surgery, after TPLO, and then again, I believe 2 weeks later. They received 1,000 pulses at about 0.15 millijoules per millimeter squared. And then the study on the right, that was Dr. Kiva's her study, where they looked at radiographic bone healing, and it was blinded by the radiologist as to what treatment the dogs received. And they did find superior bone healing in the shockwave group compared to the control group at that 6 and 8 week mark. The study on the left was Kate Barnes. Basically, they also looked at bone healing radiographically and didn't necessarily appreciate a difference, but they also took it a step further and looked at some kinetic gait analysis information. And it's really nice because they actually found some changes. You know, if you just first look at this, you can see that the dogs that were treated with shockwave had improved vertical impulse and peak vertical force at 2 and 8 weeks after surgery compared to the controls. And that's great. But what I really get out of this is we know that if we do surgery, that immediately following surgery, the dog's going to be worse. And then following a TPLO, they're going to gradually get better, which we see that dip and then improvement. So if you look at the red line here, we see that traditional dip at 2 weeks, and then they start that upward trajectory of improvement. But what's really interesting to me is if you look at the shockwave, the blue, following surgery, they never really had that dip down and then had to make headway of improvement. They just started out with improvement, which I think really holds true to the analgesic effect immediately following surgery as to why these dogs were doing better at that 2 week mark compared to that traditional downward trajectory and then upward. So to me, I found that quite interesting. Katie Barnes' group also looked at a TTA model, and again, great evidence because it's a level 2 study with moderate risk of bias. They took 40 stifles following TTA, and they had various groups. They had a group that got a bone graft with the TTA and shockwave therapy. They had a group that got just the bone graft without shockwave therapy, a group that got neither bone graft, and a group that got no bone graft and shockwave therapy. They treated them at the immediate post-op period, and then again at 4 weeks with 1,000 pulses at 0.15 millijoules per millimeter squared. And what they found was that at the 8-week mark, there really wasn't a big difference between any of the groups, but the dogs that received the bone graft with shockwave therapy had improved osteotomy gap healing density. So what that tells us is that the usage of shockwave therapy with bone graft can help stimulate an early response for bone graft in incorporation and facilitation of healing. And so for me, where I'm thinking about using shockwave therapy for bone healing is going to be where patients may have expected delayed healing. So our geriatric patients, potentially our toy breed dogs with distal radius and ulnar fractures, where we know the metaphyseal blood supply is not going to be very good, or patients that have other comorbidities, patients where a bone graft has been placed, especially if it's a non-union, any of the arthrodesis cases where we've placed bone grafts. Also patients where we're following up at various time points after surgery and we're not seeing the type of bone activity we would want to see. Patients with documented delayed or non-unions. And then I'm typically using about 750 to 1,000 pulses. That's usually at about an E6 setting, which is equated to a 0.15 millijoules per millimeter squared energy density. And then we're going to do the initial treatment, and then I'm going to do probably a total of 2 to 3 treatments every 2 weeks. So my standard approach to these is a series of 3 treatments separated by 2 weeks apart for pretty much any of my conditions. Now, tendinopathies are the ones where I really am always looking for something that's going to help us in improvement of these, whether it's an Achilles tendinopathy like we see here in this radiograph. We know that this isn't an acute Achilles tear. We know it's not an Achilles avulsion. We can see the swelling. We can see the remodeling off the calcaneus. We can see the calcification within there. We know this is a chronic Achilles tendinopathy, as well as the image on the right where we can see that bit of calcification. And so very similar to bone, it's thought to improve blood flow and neovascularization and release of growth factors. And we see an increase of growth factors such as tumor or transforming growth factor beta 1, insulin-like growth factor 1, as well as increased extracellular matrix production. And, you know, if we go back and think about, okay, if we're injecting biologics in these patients, particularly like platelet products, what's the goal there? Well, to help act as an anti-inflammatory, but also upregulate cytokines, chemokines, and growth factors. Well, we're getting the exact same response with shockwave therapy. There was a rabbit model study of patellar tendinopathy that found increased tensile strength. So again, not just healing, but improvement in biomechanical strength, which is very important because I do feel like, at least in our veterinary patients, we see much higher re-injury rates. And it's likely due to the fact that those tissues aren't fully healed and they're not conditioned and as strong as they should be before we get patients back, in particular to sport or work. And so if we're able to utilize something to increase the biomechanical properties of the tissue, I'm certainly all for it. And so from a tendinopathy standpoint, this was a study from back in 2015. These were client-owned dogs. They had a shoulder lameness. It was suspected it was due to a supraspinatus or a biceps or medial shoulder. It's a retrospective study, so it's a level 4 with a high risk of bias, which unfortunately means that evidence exists, but we have to be very careful with interpretation. And they took these 15 dogs. All of them failed conservative management, but that could have basically just been here's NSAIDs and rest with no actual formalized rehabilitation. They received shockwave therapy, 3 treatments, 3 to 4 weeks apart at 750 pulses, unknown energy density. And then at 4 weeks post-treatment, 9 of the 15 were examined. According to the authors, they all had a resolution of lameness from a subjective visualization standpoint. Long-term follow-up, they see about 65% 94% had improved or resolved lameness. So I think our takeaway from this can be that we see a positive improvement in healing in patients that have received really no treatment. Tendinopathies where they've just rested and haven't improved, and all we do is shockwave therapy, we can expect some improvement in those patients. Another study was from Dr. Lehman for her residency study, and I think Dr. Kristen Kirkby-Shaw was involved in this study as well. These were client-owned dogs that had confirmed supraspinatus or biceps tendinopathy. Unfortunately, it's a retrospective study, so it's a level 4 study with high risk of bias. But these 29 dogs, basically, they underwent shockwave therapy for 3 treatments, 3 weeks apart, and it was combined with therapeutic exercises, so some degree of a formalized rehabilitation plan. Unfortunately, it wasn't fully known about the energy or number of pulses, but via owner assessment, which you have to kind of take that for what it's worth, about 85% of these dogs improved with an average recovery time of about 16 weeks. Interestingly enough, they did find an association between the severity of the lesion and the outcome, with dogs that had more moderate to severe lesions, better outcomes. And so the takeaway there, I think, could be extrapolated to say, if we have these dogs with really severe musculoskeletal ultrasound changes with very chronic tendinopathies, we could certainly consider shockwave therapy to take that core lesion and hopefully with other modalities, get that to potentially heal for us. So where am I using it for tendinopathies? Well, really any patient that I diagnose with a tendinopathy, a patellar tendinopathy, supraspinatus, biceps, medial shoulder, Achilles, flexor carpi ulnaris, iliopsoas, any patient prior to an ultrasound-guided perilesional platelet injection of either PRP or ACP, all my patients with medial shoulder syndrome, my first approach is conservative with all of those. And so what happens is as they get ultrasounded, we then do intra-articular PRP or ACP. And then prior to injecting, I will shockwave the shoulder. I put them in hobbles. I repeat that process every 2 weeks for a series of 3. I try to get them out of the hobbles at the 6-week mark. They start a rehab program at the 2-week mark. Hopefully by that 6-week mark, we can get them out of the hobbles and we can start muscle building. I use about 750 to 1,000 pulses in an E6 setting, so 0.15 millijoules per millimeter squared. And then again, for all these, it's going to be our initial treatment followed by 2 to 3 treatments separated by 2 weeks. With desmopathy, so we know that 100% almost of every dog following a TPLO is going to get some thickening to the patellar ligament. It's not always painful, but in some cases it is painful. And so there's actually a really nice study that came from Dr. Gallagher and Alan Cross in Georgia, where these were client-owned dogs following TPLO that had clinically relevant patellar ligament desmitis. And this was considered a level 2 study, so a low risk of bias, high evidence. These 19 dogs underwent 600 pulses at an E6 setting. They underwent this at 4 weeks and at 6 weeks. And then basically what they looked at was the patellar ligament thickness. And they found that it was actually less in the shockwave group at 6 and 8 weeks compared to the control group. And so, I think if you have those patients, especially if you're a rehab veterinarian and you see these patients following a TPLO, and not just that you see that there's patellar ligament thickening, but the dog's lame and you go to push on it and the dog says, ow, that would be a good opportunity to utilize shockwave therapy for sure. Lastly would be the discussion on osteoarthritis. And so if we look at what it's thought to do, it certainly helped to thought with joint pain. We'll go through some studies that have shown some improved objective outcome measures. The thought process has been to decrease inflammatory mediators, in particular interleukin-1 beta and tumor necrosis factor alpha. These are actually the 2 main driving inflammatory mediators with OA, amongst a whole barrage of other things. But many a times when we're doing clinical studies, when we're looking at markers, interleukin-1 beta and tumor necrosis factor alpha are always involved. Again, though, I love chondrocytes. They're great little cells to work with. They're very finicky little cells. They love to roll over and die on you. And so, we do want to be careful using shockwave therapy directly on the articular cartilage to prevent chondrocyte damage. It could be that it doesn't do anything. We just don't know at the current moment. So we do have two studies of dogs, and these dogs both these studies, they received one treatment every week for 3 weeks. I think it was about 2,000 pulses of about 0.13 to 0.15 millijoules per millimeter squared. The study on the left was out of VCOT in 2016. It's a level 2 study with a moderate risk of bias. What they did was they took these dogs, they treated one side. These dogs had bilateral hip OA, and they also compared it to dogs without hip OA. They used objective gait analysis. So we can see from this chart from the peak vertical force that the healthy group obviously was putting more weight on their back legs. We expect that. The dogs with hip OA were putting less weight on the back legs, but we can see that at day 0 in the treated group, there was actually a very big difference between left and right symmetry in peak vertical force. And then they followed up at day 30, 60, and 90. And you can see what happens is that things start to normalize a little bit, such that by day roughly 90, they're almost symmetric on both back legs. But what I find interesting is these dogs were treated once a week for 3 weeks. We see improved objective gait analysis not only at 30 days, but it continues out to 60 days as well as to 90 days. The study on the right was one out of Veterinary Record in 2017, which again was a level 2 study with a low risk of bias. They did the same thing. They treated one hip and then followed these dogs out. They treated them once a week for 3 weeks. And again, we see from time 0, the lame leg has a less percentage of body weight being placed. And at 6 weeks, 3 months, and 6 months, we see normalization of the symmetry between the two hind legs. And so what we see here is not just improvement following a shockwave session, but we see a long-standing improvement, which I think is really nice. This is another study of dogs with stifle OA. This was in 2005. They took 14 dogs. It's a level 2 study with moderate risk of bias. They had 7 treated and 7 untreated dogs. They underwent 1,500 pulses at about 0.14 millijoules per millimeter squared 3 times at 3-week intervals. They looked at both objective gait analysis and range of motion at 21 days following. And what they found was there really wasn't any statistically significant changes between the treated and the untreated groups. They said that in the dogs, of the treated dogs, the peak vertical force had a trend towards improving at 4 out of 7 of those, as well as a trend of improved range of motion. And I hate when trends are stated in a study, because what that tells us is one of two things. Either we continue that out for a longer duration and we never reach statistical significance and it's not going to ever be significant, or we take it out longer and we do see a change. And so, I think one could argue to say then maybe we should have taken this out longer or changed a few things. Because, if you look at the peak vertical force and you look at the range of motion in the treated groups, you can see that ultimately there is a slight uptick as we get to that further point at around 98 days following. And so, the question there is, do you take that out a little bit further? But, I think this just goes to show that even though there are studies that show statistic changes between dogs with OA, not all the studies show us improvement as well. So we have to also take that into consideration. And so for OA management, for me, I'm going to certainly think about using shockwave therapy for patients at the beginning of a flare-up. And that means I've counseled owners on what a flare-up is and how to understand that one is coming on, or a patient during a flare-up in conjunction with a formalized rehabilitation program. And I'm using it as part of the multimodal management. If you really said, I only have X amount of dollars and I see lots of OA patients and I want a single-use modality that I can have a long-term effect and even potentially use for maintenance, I would tell you to go with the shockwave therapy compared to some of the other modalities that are out there. I'm typically using 1,000 pulses at an E4 to E6 setting. The initial treatment followed by 2 to 3 treatments every 2 weeks. That's going to be for that flare-up period. But if we have those older patients or geriatric patients with poly joint OA, you could certainly do it monthly, or you can follow up doing it every 4 to 6 months or every 3 months, or find what works for the dog. I think from at least those hip studies, we can be pretty confident in that the pain resolution will likely be improved at least 3 up to sometimes 6 months. And so, coming in from a maintenance standpoint at those time points would probably prove to be effective. And so in summary, shockwave therapy really uses a focused sound wave to hit the tissues to cause a biologic response, to help minimize inflammatory mediators, increase the release of growth factors. And what I say is we're simply increasing the healing response in tissues that have an otherwise poor healing response. It's just another tool in the toolbox. It's best used as part of our multimodal management process. We do need more research. And I hope that as shockwave therapy becomes a bit more of a buzzword and people are looking into it more, we're going to see the literature to support its usage. I know there was just recently a study published on the usage of shockwave therapy for, I believe, supraspinatus and infraspinatus. It was a case series, I believe. I haven't had a chance to read it yet, but hopefully I'll be able to get that under control and take a look at that here shortly. And so when you're thinking about where you can utilize shockwave therapy for, I would say for our tendinopathies, for our delayed and non-unions, as well as osteoarthritis.